Welcome everyone, and yeah, we'll get started since it's just hit noon on the West Coast. So thank you everyone for being here, and we are really glad that you're here for today's session on the brand new 2026 Dyslipidemia Guidelines. Um, there's some really great updates in these guidelines that we think will be directly relevant to your practice. And yeah, we'll jump into quick intro. Thanks, Dr. Dixon. So, quick overview of the Heartbeat California program in case you're not familiar. My name is Jen Swanstrom. I am the program manager of the Heartbeat California program. As you probably already know, and that's why you're here, cardiovascular disease is the leading cause of death. And one of the greatest risk factors for it is high cholesterol. Um, and in the state of California, we received this 5-year cooperative funding agreement grant from the Centers for Disease Control and Prevention to implement and evaluate evidence-based strategies contributing to the prevention and management of cardiovascular disease in populations that are disproportionately at risk. We call it Heartbeat California within California. And we just started year 4 out of our 5-year grant. And we are currently working on gathering our data from this last year. But if you want to know more about it, you are welcome to join our fall Healthy Hearts California Learning Collaborative meeting and reach out to me directly for more information. But next slide, please. So quick overview of our agenda. We'll be talking about the significance and prevalence of the risk assessment and lipids, how the guidelines approach diagnosis, cover treatment goals, management, and some patient case scenarios. We'll also have a Q&A portion at the end, so if any questions come up during the presentation, please feel free to share those using the Q&A feature in Zoom. So lastly, it is my pleasure to introduce today's faculty presenter, Dr. Dave Dixon. He is the Nancy and Ronald McFarland Professor of Pharmacy and Chair of the Department of Pharmacotherapy and Outcomes Sciences at Virginia Commonwealth University School of Pharmacy, with a joint appointment in the Division of Cardiology at VCU School of Medicine. He brings deep expertise in cardiovascular pharmacotherapy, and we're very fortunate to have him with us. So, Dr. Dixon, I'll turn it over to you. Thanks so much.
Thank you, Jen, and I want to thank everyone for joining us today. This is, to me, a really exciting topic, so I will try to stay on time, as I could talk all day about dyslipidemia and the current guidelines, which do include a number of key changes. So we're going to jump right in and kind of go through with our learning objectives in terms of what we want to accomplish today. And I think one of the big changes that you've probably heard about is the PREVENT calculator and some changes in terms of how we risk assess patients. There's also more guidance around the role of coronary artery calcium scoring and how that can be a useful tool to help risk stratify select patients. We're going to talk about treatment goals, which are back. So if you missed them, you can now be excited that we do have well-defined goals of therapy for LDL cholesterol, as well as non-HDL and APOB. And so we will also discuss and kind of disentangle these 3 different surrogate markers and when they should be used and really what you should do in practice. And then lastly, of course, apply the guidelines to a patient case. I do have a few slides on the management of hypertriglyceridemia. If we have time, I will cover those. But obviously, the primary focus of today's talk is really on reducing LDL cholesterol as a primary approach to reducing ASCVD risk. These are some commonly used acronyms and abbreviations. So the importance of dyslipidemia, as mentioned by Jen at the beginning, dyslipidemia is a causal factor in the development of atherosclerotic cardiovascular disease. Nearly 1 in 10 deaths every year can be attributed to high LDL. And one thing that I think it hasn't changed, but I think the evidence is further confirmed that in most individuals, what is really driving elevated LDL is genetics. Certainly, diet and lifestyle and other comorbidities definitely can influence LDL levels, but for the majority of patients, especially those with LDLs above 160 and especially above 190, in most cases, these are really genetically driven and therefore require treatment. The goal ultimately, of course, is we want to reduce LDL cholesterol, but we want to think about it from the perspective of cumulative lifetime risk or lifetime exposure to LDL cholesterol. And that's a big theme of this new guideline. That's a slight change in just in terms of how we think about LDL. So to illustrate that point, here you can see that we have cumulative lifetime risk of MACE on the left, cumulative lifetime LDL exposure on the right, and then at the bottom we have the age in years. And so if we take an individual with an average LDL cholesterol level of approximately 130 milligrams per deciliter, the LDL is not just a number that is a snapshot in time. That elevated LDL, if it's allowed to stay elevated, of course, as time passes, there's an accumulation of LDL cholesterol presence in the circulation, which then, of course, can initiate and propagate atherosclerosis. And typically, we see most ASCVD events in that sixth and seventh decade of life for that very reason. But if we can lower the LDL cholesterol moderately with a 30% reduction with a statin, for example, you can see that we really bend the curve in terms of reducing that risk. And maybe even more importantly, delaying early onset ASCVD, which we know can certainly play a big role in reducing life expectancy. If we reduce the LDL by 50% or more, you can see that we get an even further flattening or well, not quite flat, but a decrease in the risk of events. I don't think that, we'll ever getting to zero is possible, but certainly illustrating here that the more we reduce the LDL, the more reduction in risk. This is especially important for patients with familial hypercholesterolemia, which has a prevalence of 1 in 250 to 300 individuals in the United States, much more common than you would think. These individuals have LDLs that are well above the typical patient. And you can see here, untreated, these individuals are at increased risk of premature ASCVD and premature death. So we want to globally kind of think about reducing this cumulative lifetime exposure to LDL. In recent years, there's been a number of landmark clinical trials really further testing this hypothesis of how low is low enough for LDL cholesterol. And going all the way back to the Scandinavian simvastatin survival study, or 4S trial, published in 1994, all the way to the Vesalia CV trial that was just published in the past year, you can see that we've continually been able to test this hypothesis of what if we push the LDL a little bit lower? If we went a little bit lower, what happens? And there is a linear trend where the more we lower LDL cholesterol, the further the reduction in risk that we achieve. And so kind of the answer that we're at right now is lower LDL for longer is best. So let's move into risk assessment, goal setting, and statin intensity. And this is where, again, there's been a lot of changes. So the ASCVD risk categories or statin benefit groups, as they were referred to in prior guidelines, have been shaped a little bit differently. So obviously those that already have established clinical ASCVD, patients with diabetes, patients with severe hypercholesterolemia, which the surrogate marker we use for that is an LDL above 190. And our primary prevention population is pretty much the same. But what's really changed is this addition of patients that have subclinical atherosclerosis. So we're going to unpack that today. And then for primary prevention, I want to illustrate the point that this is really only referring to patients with no known ASCVD, no known subclinical atherosclerosis, no diabetes, and their LDL is below 190. Okay, so it is true that you can have diabetes, you don't have ASCVD. We kind of think about that patient as being a primary prevention patient. But given the elevated risk in the diabetes population, we sort of carve them out as a separate risk category. So just be careful lumping those kinds of patients in with that primary prevention bucket. Really, we're talking about patients who only have ASCVD risk factors. They're likely younger, maybe low to intermediate risk type patients, with some exceptions, of course. So I think that's a really important point. So LDL goal setting, like I said, LDL goals are back. These are completely based on the patient's risk. The higher the risk, the lower the goal. And there are three goals. And so I like to communicate this as the rule of 100, 70, or 55. And basically, we're thinking about what's the patient's risk of ASCVD and then matching that to a corresponding goal to reduce that risk. I'm not going to read through all of the goals, but I think I do want to walk you through the three goals and the types of patient categories where it's appropriate. And one big change is really embracing the LDL goal of less than 55. This is indicated for those very high risk ASCVD patients, patients with significant subclinical atherosclerosis. You can see the coronary artery calcium cutoffs here. If you have severe hypercholesterolemia and you already have established ASCVD, LDL goal less than 55. So these are really the only sort of three categories of patients where we're going to apply our most intensive LDL goal. The corresponding non-HDL goal, of course, is less than 85 because it's always 30 points higher than the LDL goal. This is where it gets complicated, right? So LDL below 70 applies to a larger proportion of patients than it did in prior years. So a clinical ASCVD patient that's not at very high risk, the goal is less than 70. You can see the cut points there based on the CAC score and the percentile. For severe hypercholesterolemia, if we've confirmed or it's very probable that they truly have familial hypercholesterolemia, if they have other risk factors or subclinical atherosclerosis possibly, then we're going to target less than 70. And for the diabetes population, if they have ASCVD risk factors in addition to diabetes, that's just about an automatic LDL below 70. There are some diabetes specific risk enhancers that we'll also talk about that can be used to further risk stratify that population. And I always like to remind folks that this applies to those with type 1 and type 2 diabetes. The leading cause of death in both of those groups is ASCVD. And then in that primary prevention population, if the prevent ASCVD score is 10% or greater, we consider them to be high risk primary prevention. And so we're going to target an LDL below 70. And then lastly, we have an LDL goal of less than 100. Obviously, that doesn't apply to patients with established disease. Patients that have lower levels of coronary artery calcium or a lower percentile score, the severe hypercholesterolemia patients, where we're not sure that they really have FH, they don't have risk factors in subclinical atherosclerosis, we can be a little less aggressive. And of course, that diabetes patient that doesn't have ASCVD risk factors, which is not common, it's typically going to be your younger patients. And then a prevent score less than 10%. So these are the LDL goals. These are all of the various populations. It is a lot to digest. I definitely recommend sort of having a copy of this somewhere handy because it is a bit more nuanced than it had been in previous years. So we've talked about goals. I want to address misconceptions kind of throughout this talk or areas where there's been controversy or questions that I get asked a lot. And now that we're able to achieve pretty low levels of LDL cholesterol, especially with the advent of the PCSK9 inhibitors, I get this question about low LDL all the time. From an evolutionary perspective, we didn't really evolve to keep our ApoB levels elevated, but we do have the metabolic machinery to make them. And if you think about it, it makes sense. We do need these lipoprotein transporters. That's really what lipoproteins do, right? They transport things throughout the body, transport energy, right? So we do need the ability to produce these to help transport energy. They do play a role in tissue repair, a modest role in our innate immunity. And so it certainly makes sense that we can make them. But the fact that we make too many of them is sort of a modern problem. And basically, our capacity to make ApoB is amplified and frequently activated because of diet, lifestyle, and of course, our kind of environment. Other comorbidities that we have. We live much longer than, of course, our ancient ancestors did typically. So all of this kind of contributes to this persistent dyslipidemia. From a genetic perspective, loss of function mutations exist. There are individuals that simply don't produce ApoB. There are individuals who don't produce PCSK9, and that's actually how we discovered that particular drug therapy target. These patients have ApoB or LDL levels between 10 and 40, and they virtually don't get ASCVD. I've only seen one of these patients in my entire career, and that was for hypertension, not for elevated cholesterol, and they were living a very healthy life otherwise. From a clinical standpoint, we do have long-term data beyond 8 years where we've maintained LDL levels of around 30 milligrams per deciliter with evolocumab plus a statin. We also have some similar data with alirocumab plus a statin. And the results of that are pretty clear that we do see a persistently lower rate of adverse events compared to placebo. It does not exceed the adverse event rate in the original placebo arm of the original trial. And we continue to see further reductions in ASCVD. So all that put together, kind of the conclusion right now is for survival, we need an ApoB or LDL level somewhere between 10 and 20. When you're born, it's probably somewhere between 10 and 40 for most newborns. And so based on what we know currently, it seems pretty safe. And I don't think we have to worry about driving the LDL too low and there being significant safety and harm there. Moving into treatment. So statins remain first line. Nothing's changed there. These are generically available, inexpensive medications. A lot of third-party payers are actually just waiving copays for a lot of patients to take their statin. High, moderate, low intensity, of course, recommended kind of based on risk. There's really nothing new here from that standpoint. What is new is when we think about those patient groups that we talked about at the very beginning, well, which statin intensity do I use, right? That's the next logical question. So you can see in red, the red column here, or the second column, high intensity statin therapy is indicated if you have ASCVD, severe hypercholesterolemia, if you have significant subclinical atherosclerosis, which we're defining here as a CAC score above 100, if you have diabetes, or if your prevent score is greater than 10%. A moderate intensity statin, of course, you can see we're using for patients that are kind of not quite at that threshold, but they have a CAC score, but it's not above 100. That diabetes patient that has no other risk factors, and then for select primary prevention patients, if that 10-year risk score is less than 10%. Low intensity statins not here because really to significantly reduce risk, we need to lower the LDL, preferably by at least 30% if we're really going to move the needle on reducing risk. But if someone can't tolerate a moderate or high intensity, a low intensity statin, of course, would be appropriate. It's just that we would need to combine that with non-statin therapy to achieve goal. But we don't start with low intensity and titrate up. We really do want to continue to start with fixed doses based on the clinical trials. Some other questions I get asked about statin therapy. So do statins really cause muscle pain? Yeah, they do. I'll just say it. They do. Statin-associated muscle symptoms are real. I think where there's some issue is how common is it where the statin is really the cause of those muscle symptoms? That's about 5 to 10% of cases. But if you look at surveys of people that have taken statins, you'll see estimates as high as 30 to 40%. There have been some really clever studies where they've actually explored the concept of the nocebo effect. So patients that have had muscle symptoms each month get a different pill bottle. They don't know what's in there. Sometimes they get a statin, sometimes they get a placebo, and they're kind of keeping track of their symptoms. And a couple of these studies have shown that about 90% of their symptoms were likely due to this nocebo effect, where we're aware that something can cause harm. So we're much more sensitive and attuned to that. And then we quickly connect those dots that, when my knee hurts, I started the statin a month ago. It must be the statin because I read online that statins can cause muscle pain. It's not that the patient's not feeling that. It's just that it's probably not caused by the statin. Muscle aches, pains, joint pain, which group of people have it the most? It's those in middle age. Um, and those are also people typically that are starting statins. That's typically kind of when that, conversation starts for a lot of people. So again, doesn't mean we should dismiss symptoms. We still have to, if the patient's not tolerating the statin, we still have to kind of move on to other options, but just know that it's probably about 5 to 10% of cases. Creatine kinase is something that we can monitor. The problem is that it's not specific to statin-associated muscle symptoms. Someone can have muscle complaints and have a CK of 0. I have patients with CK levels that are elevated and have no muscle pain. However, if you suspect rhabdomyolysis, so severe debilitating muscle weakness and pain, it is perfectly reasonable to check a CK because that's part of the diagnosis and workup for rhabdo. Coenzyme Q10, it's harmless. If a patient wants to take it, it's fine. It's another expense, it's another pill. So I definitely have that conversation. It's probably not effective. But again, not routinely recommended. But if I have a patient that's very passionate about it or they believe that it works, I don't really get in their way because it's pretty harmless. Do statins increase the risk of type 2 diabetes? They do. The exact mechanism of this, there's some really good hypotheses out there. One of the leading ones is that statins disrupt cell-to-cell insulin signaling. And so there's some disruption of the ability for insulin to do its job, basically. This is a dose-dependent effect. It's more common with high-intensity statins. If you look at the data and you look at those with risk factors for getting diabetes, all of the new cases of diabetes are in those patients. The Jupiter trial did a great analysis of this. And patients that had no risk factors for diabetes that were on Rasuva 20, none of them developed diabetes. So the way I think about this is you're on a train to a destination that's already pre-planned. The statin speeds up the train a little bit. That's pretty much all that's happening. I would also argue that if you have pre-diabetes, you should, in a lot of cases, those patients would probably likely need to be on a statin anyway for reducing their cardiovascular risk. And where this stands is that the benefit of statin therapy outweighs the risk. If these individuals are going to develop diabetes anyway, they will be on a statin eventually anyway, right, to reduce ASCVD risk. So it's something you have to work with patients about if they have concerns, but by and large, we should continue to initiate statins in those patients. Can statins be used in patients with liver disease? Yes, statins are safe and likely beneficial. There's emerging data in patients with metabolic associated liver disease. Those patients that have chronic stable liver disease, statins are safe. Now, if you are in acute liver failure or you have active cirrhosis, you're correct. Like we would not want to continue or start a statin in that patient. Routine monitoring of the liver function test is not recommended by the guidelines or the FDA. It's not all that helpful in actually identifying acute liver disease. What it does help us do is identify mildly elevated LFTs that are pretty common after starting a statin, and then they normalize over time. And it creates sometimes false or unnecessary referrals and escalation of care and extra tests that really are unnecessary. So if you suspect someone is certainly developing more, notable liver disease, they have symptoms, certainly check the LFTs. It's reasonable to check the LFTs at baseline because you wouldn't want to start a statin if someone has a AST or ALT that's already 3 times the upper limit of normal. But by and large, they're very safe in those patients with stable disease. Some patients report memory loss and cognitive impairment. Is there any truth to this? So unfortunately, it's still in the prescribing information for statins. I know there are conversations about whether that warning or precaution should remain. Statins are weakly associated with memory loss and cognitive impairment. This is overwhelmingly from anecdotal reports, post-marketing surveillance, not great data. If we look at the larger trials, there's no signal of this potential harm. And what we actually see in some of the more recent evidence is that statins are more likely to be neuroprotective than harmful. And so there's a lot of research in this area. Um, Definitely something that, comes up occasionally with patients, but typically you can provide reassurance that statins are more than likely helping them than harming them. Okay. Clinical ASCVD. So I did want to kind of start to go through some of the different risk categories, particularly subclinical atherosclerosis, but I think it's important to cover ASCVD first. Very simply put, this is symptomatic atherosclerosis. You have stenosis or blockage of the artery that exceeds 50%, whether that's the coronary arteries, the carotid arteries, peripheral arteries, the aorta, any stenosis beyond 50%, typically you're going to have symptoms. And so this is kind of what we're talking about and how ASCVD is defined. And of course, these are focused on patients that have had some kind of event, some kind of major procedure. Again, the stenosis is severe enough to where they have had symptoms or required some kind of intervention. Clinical ASCVD, very high risk. The definition here has not changed since the prior dyslipidemia guideline. You can get there by having two or more major ASCVD events, as outlined here, or if you have one major ASCVD event plus two high-risk conditions. Where does this come from, you might ask? Well, this comes from looking at some of the non-statin trials where we've added, say, a PCSK9 inhibitor or ezetimibe to a statin in these higher risk patients with established cardiovascular disease. And we tried to identify which groups were more likely to benefit from that additional non-statin therapy, which patients were at highest risk. These are the factors associated with patients at the highest risk. And so that's why we have this distinguishing kind of category here within those patients that have ASCVD. Subclinical atherosclerosis. So it's not a new kid on the block, but it is in the sense of being so firmly incorporated into the guidelines. And this is basically asymptomatic disease, is the way I think about it. This is primarily detected using coronary artery calcium testing, which is done using a CT scan. The radiation exposure is quite a bit less than a mammogram, and typically you're only having this done once in your lifetime, possibly twice, but it's not a test that you're getting done over and over again. We can also see calcium on routine chest CTs, carotid ultrasounds, or coronary CT angiography. We call that incidental CAC because we weren't looking for it. And as you see in the image on the left, a CAC score of 0, there's no white. And if you look at the CAC score of 29 and then 250 and then 1200, you see a lot of white. That is the calcium. Calcium is a byproduct of the atherosclerotic process. We can visualize that calcium. The only thing that we're visualizing are the stable plaques. It does not help us see unstable plaques that have not been solidified with that kind of buildup of calcium. So that's a word of caution in terms of we can misinterpret a CAC score, and we'll talk about that in a moment. Who is this ideal for? This is that primary prevention patient. They're at least 40. They have a 10-year prevent score in that borderline to intermediate range of 3 to 10%. And rarely in even lower risk patients if they have a significant family history of ASCVD. As I mentioned, this only shows us the calcified plaque. If the score is 0, it may need to be repeated in 3 to 7 years. And it's important to recognize that a CAC score is less reliable in patients with diabetes, tobacco users, and those under 40. So ideally, we really try to not order CAC testing in those patients because they really could lead us to a wrong decision in terms of treatment. So not quite fully covered by insurance yet. I anticipate that's going to change. At most institutions, the out-of-pocket cost for CAC testing is around $100. I've seen $200 to $300 at some places, but most of the time it's in that $100 range. The severe hypercholesterolemia group, so these are individuals with an LDL of at least 190. Most of the time, this is from a polygenic lipid disorder, so multiple small effect gene variations. That's the most common cause of hypercholesterolemia. It's not quite FH because familial hypercholesterolemia is a monogenic lipid disorder. There's a single variant that impairs the functionality of the LDL receptor. Heterozygous patients, again, as I mentioned, the prevalence is 1 in 250. Homozygous, yeah, it's a bit rare. Somewhere in 1 in 300,000 people is the current estimate. This is underdiagnosed, so those prevalence estimates are very difficult, but based on more contemporary data, this is where that stands. And then, of course, we always have to rule out secondary causes. There are various conditions that can increase the LDL significantly, including some medications I have listed here. So we certainly have to rule those out before we go down the pathway of trying to work someone up for FH, for example. Our diabetes population, right? So very high risk for cardiovascular disease, leading cause of death. But the risk is heterogeneous. Not all diabetes patients are the same. If you develop type 2 diabetes, let's say at age 22, and now you're 57, you've been exposed to that disease for a long time. Whereas if you were newly diagnosed at age 57, that's very different, right? Your exposure to the disease and the associated risk is very different. There are diabetes-specific risk enhancers, and these are used in diabetes patients between age 20 to 39, where they're not older, right? So that age-associated risk is kind of not an issue, but we have to think longer term because we're thinking about prevention, right? We're thinking about reducing that lifetime cumulative LDL exposure. So we have these specific risk enhancers in that younger patient, if they've already had diabetes for a long time, if they have albuminuria, if they have chronic kidney disease, other signs of diabetes related complications, that may push us to go ahead and consider starting a statin in that younger patient. Again, thinking about the long-term risk. In those primary prevention patients, so again, no ASCVD, LDL below 190, no evidence of subclinical atherosclerosis, and no diabetes. The guidelines recommend this CPR framework. So calculate the risk, classify it, personalize that risk, reclassify and reassess based on maybe a CAC score or other risk enhancers or other factors that maybe aren't in the prevent calculator, and then decide and treat. And so this sort of gives us a framework to work with when we think about evaluating risk in these patients and then getting to a point of, do we recommend treatment or not? The Prevent ASCVD score, there's a link there. You can also use the American College of Cardiology app that is available on the iTunes Store and Google Play. It's the new calculator that replaces the previous ASCVD risk estimator. This can calculate 10-year and 30-year risk in adults as young as age 30 all the way to age 79. This should only be used in those primary prevention patients. We do not need to calculate the risk score if you already have established ASCVD because we already know your 10-year risk is high. Subclinical atherosclerosis, same thing. If your LDL is above 190, and if you have diabetes. Now, diabetes, we can use it if there's ambiguity or maybe the patient needs a little more convincing that they should start a statin. But by and large, for many years now, it's been well accepted that essentially all patients with diabetes should be on statin therapy anyway. So we don't want to misuse the calculator in those 4 groups. This is what the output looks like. One of the most important things here, and I intentionally made this mistake to show you at the very top, this calculator has 3 outputs. Total CVD, which includes ASCVD and heart failure risk combined, and then you can look at ASCVD and heart failure separately. For dyslipidemia, you have to click on the ASCVD tab, okay? Because that is the risk that we are using to make a decision about statin therapy. We're not using total CVD risk. because statins don't directly reduce our risk of heart failure. They indirectly do, but not directly. So, very important point there. There's also some optional predictors here at the bottom, your UACR, urine albumin creatinine ratio, A1C level. Zip code is new because that's getting us a sense of the patient's environment where they live, work, play, worship, etc., and not so much focused on just their race ethnicity, which was a component of the previous calculator that is no longer included in this new prevent calculator. So if the calculator score is 0 to less than 3%, it's pretty much lifestyle only. The only exception to that is if the LDL is above 160. That's a primary hyperlipidemia. If we've ruled everything out, you're doing what you're supposed to do lifestyle wise, and your LDL is still above 160, you probably have a polygenic lipid disorder. There's multiple small mutations there causing your LDL to be much higher than average. If you're borderline 3 to less than 5%, we're going to do lifestyle unless you have at least one risk enhancer present. And then we start a moderate intensity. You can consider CAC testing in these patients as well. An intermediate risk patient between 5 to less than 10%, kind of an automatic to go ahead and start a moderate intensity. If that patient's not quite convinced, this is where coronary artery calcium can be helpful. And then lastly, the high risk patient, we're going to start a high intensity statin if that 10-year risk is above 10%. So I've said risk factor and risk enhancing factor, and I get asked this a lot too. What's the difference? A risk factor is independently, consistently predictive of risk. These are our bread and butter risk factors, or our factors associated with risk, I should say. Age, which is the most powerful, sex, hypertension, dyslipidemia, chronic kidney disease, diabetes, obesity, smoking. Risk enhancing factors are not independently predictive by themselves to anchor the risk assessment. So we use them to refine the risk assessment. And here's a full list. These have not changed since the last guideline. We are applying these again to that primary prevention patient when we calculate the 10-year risk and they're in that borderline group. We don't need to use these if you already have ASCVD. We don't need to use these if you have diabetes because we don't need this information necessarily to determine if we should treat your LDL. So again, these have not changed. I'm not going to read through them, but just know that's kind of the big difference between risk factor and risk enhancing factor. All right, everyone's favorite topic, lipid measurement controversy. This is a big difference between dyslipidemia and hypertension. Hypertension, check the blood pressure, right? It's very clear. And for lipids, it's largely LDL, but it's a bit more complicated than that. The big driver at the end of the day is really the number of ApoB particles. ApoB is a protein found on LDL, IDL, VLDL, Lp(a), and chylomicrons. Most ApoB particles spend about 90% of their time in circulation as an LDL. However, if you have obesity, if you have diabetes, metabolic syndrome, kidney disease, etc., that life cycle changes. And so ApoB may be more prevalent, but it's not in LDL form. And so if we're only hyper-focused on LDL, we may underestimate risk in those patients because we're underestimating the burden of ApoB. And again, for 80 to 90% of patients, LDL is a good surrogate estimate of ApoB particles. And it's that trapping of those ApoB particles that really drives atherosclerosis. And so that's what we're ultimately trying to do. So why not just measure ApoB, right? Which patient is at higher risk? So patient A, they have fewer particles, but they're larger. Patient B has a higher particle number, but they're smaller. These two patients have the same LDL level. You see this play out a lot in the patients I mentioned a second ago: obesity, diabetes, metabolic syndrome. Patient B is at higher risk, but it's not because the particles are smaller, it's because there's more of them. This is another change in recent years. we used to get very much, obsessed with how large and fluffy our LDL particles were. Maybe there's some truth to that, but at the end of the day, it's about the number of particles. That is the primary driver, and that's really what we should be focused on. LDL is a calculated value. It is not something we directly measure. Directly measuring LDL is actually not that accurate because the methods vary from one institution or lab to the next. It is an estimate of the cholesterol content carried by LDL, which can be falsely low if you have even slightly elevated triglycerides. It doesn't include those cholesterol depleted lipoproteins, so IDL, LDL, VLDL, but it's very familiar to us. It's been used in nearly all the clinical trials. Non-HDL is total cholesterol minus the HDL. And what we're left with is a better estimate of the total number of ApoB particles. It has some limitations as well. It doesn't quite account for all of those cholesterol depleted lipoproteins. ApoB, on the other hand, is a direct measurement. It's the most accurate, but it's not as familiar to clinicians. It has not been the surrogate marker used in most trials. So the guidelines are still sticking with LDL. Non-HDL is a good middle ground because it's not another lab test. You can calculate it very easily from a standard lipid panel. We have goals for non-HDL, and it's a bit more accurate. ApoB is reserved for patients where we've already kind of gotten them to goal in those higher risk patients. Checking the ApoB is sort of a double check to make sure that we have really reduced their total ApoB burden as much as we should. Non-fasting or fasting lipid profile is totally fine. However, if someone has hypertriglyceridemia, a fasting profile is really preferred. There are two new ways to calculate LDL. Almost all labs have moved from Friedewald to either the Martin Hopkins or the Sampson NIH equations, which are more accurate. Advanced lipid protein testing, we did a lot of this. I know when I was starting my career out 20 years ago, we were doing this. It's not recommended. It really does not provide more or better information to inform care. It's interesting, but it doesn't really help drive treatment decisions. And as I mentioned, ApoB in those higher risk patients, maybe select groups of patients like those with diabetes, where we might underestimate the total ApoB burden. The guidelines do say you can do that in those patients, but it's not quite broadly recommended for all patients. So what about follow-up? This is critical. Ever since the 2013 guidelines, every guideline has had this class 1A recommendation. 4 to 12 weeks after starting therapy or making a dose adjustment, we should check a lipid profile. Once that LDL goal is achieved, we continue to assess every 6 to 12 months. For some reason, this has kind of gotten lost a bit. I think it's the fixed dose statin mindset, fire and forget it. But now we have really effective non-statin therapies. We have goals, and the only way to know that if this patient is well treated is to check the lipid profile. So really important point there. LP little a or lipoprotein A. This is now incorporated in the guidelines. It is an LDL-like particle. It is mostly inherited. It is a causal risk factor for ASCVD and calcific valve disease, independent of LDL, and that's really important. Okay, so if we adjust for LDL, LP little a is still a strong causal risk factor. So LP little a should be checked once in every adult's lifetime. And then you can see kind of the ranges there. It can be checked in nanomoles per liter or milligrams per deciliter. Nanomole per liter is preferred because there we're really looking at particle number. So once again, focusing on the same issue between LDL and ApoB, the nanomole per liter is preferred because we're focused on the number of LP little a particles. It is a useful risk enhancing factor. Just because we can't treat it necessarily right now doesn't mean that we shouldn't check it, because it can lead us to help identify higher risk patients to intensify therapy. It can help motivate patients. As you see on the figure on the right, that ApoA strand that's attached to the ApoB containing lipoprotein is what makes LP little a unique from LDL. And there are several drugs in the pipeline that will lower LP little a by 80, 90% plus. And I think we'll know in the next year or two if that translates to reducing ASCVD events. Non-statin therapy. There are more of them. So, as of today, the first oral PCSK9 inhibitor was approved in Enlicitide. So this is an ever-evolving landscape. I'm not going to read through this, but give you some highlights. I think the important column is on the far right. Bempedoic acid, ezetimibe, alirocumab, and evolocumab all have data that they reduce ASCVD event rates. So these should be prioritized. The bile acid sequestrants, not used as much, not great, tolerability wise, not that potent. We don't have contemporary data with these drugs. We have data, but it's old. It predates the statins. Inclisiran is the siRNA therapy that is given in the clinic every 6 months as a maintenance dose, as a sub-Q injection. We are waiting for the clinical outcome trial. Lerodalcibep is another PCSK9 inhibitor approved at the end of last year, and we're still waiting on the clinical outcome trial there. But this allows us to navigate challenges when patients don't tolerate statin therapy or if they're not achieving goals on max tolerated statin therapy. You can see that the LDL reductions we can achieve with combinations of the non-statins is significant. An additional 50 to 60% plus reduction is now feasible. And these are great alternatives or additions to statin therapy for patients that need it. Dietary supplements, niacin, and fibrates. For the focus on reducing ASCVD risk, we should not be using these drugs based on the randomized clinical trial evidence. Low dose omega-3 fatty acids do not provide benefit. A lot of the other over-the-counter supplements that people use, red yeast rice comes up a lot. There's a great trial where they compared these, and you see just the wide-ranging variability in what little bit of LDL reduction you might see. Niacin, of course, 2 negative trials. Fenofibrate has been tested multiple times. It has a role in lowering triglycerides, but not ASCVD event rates. So what I'm going to do is hit a couple of key points on triglycerides, just to make sure we have enough time for questions. So elevated triglycerides, what did they tell us? Really that metabolically speaking, we're not that healthy. There's an impairment in the handling of those triglyceride-rich lipoproteins. We have insulin resistance more than likely, and they're very common in patients with metabolic syndrome, central adiposity, MASLD, diabetes, prediabetes. The elevated triglyceride itself is probably not causal in ASCVD, but when the triglycerides are elevated, we typically see an elevated ApoB particle number. And again, those smaller, dense phenotype LDLs and a low HDL. So at the end of the day, what's driving the risk? It's the ApoB. It's not the triglyceride. And so when we're talking about reducing triglycerides, our real focus is reducing the risk of pancreatitis in patients where that's a major concern. So that leads us to kind of thinking through like treatment-wise. And so triglycerides respond incredibly well to addressing comorbidities that contribute to it, diet, lifestyle. There are some genetic hypertriglyceridemia conditions to where we really have to treat those patients with medications. As we know, many medications can increase triglycerides and, of course, various metabolism disorders. And so really, this is the starting point for all patients with high triglycerides. No real change here if you have moderate hypertriglyceridemia. If you have an indication for a statin, we're going to start a statin. Statins lower triglycerides by about 30% at the high intensity dose. We can consider icosapent ethyl if they have ASCVD or diabetes and their LDL is reasonably well controlled. For the severe hypertriglyceridemia patient, again, if statin therapy is indicated, well, let's put them on a statin because we have to address that ASCVD risk first. but we may need to add fenofibrate or a prescription omega-3 fatty acid to reduce the risk of pancreatitis. And then gemfibrozil, of course, we really want to avoid that with statins if at all possible, and only use niacin if all of these other options don't work or are contraindicated. There is a newer drug that recently got approved for severe hypertriglyceridemia called olezarsen. It's an APOC3 inhibitor. So that is another tool in the toolbox. But by and large, for these patients, our focus is more on pancreatitis risk and not so much ASCVD. HDL, there's not a lot to say that's new. It is a great predictor of risk. It is a terrible drug target. Multiple trials showing no benefit with raising HDL, and so we should really just focus on lifestyle modification, avoid tobacco, exercise, maintain a healthy weight, don't get diabetes. All right, so our case here. So briefly going to go through this. So 58-year-old man with dyslipidemia, being screened for dyslipidemia, no prior ASCVD. He does have risk factors. He quit tobacco 3 years ago. He's on an antihypertensive and metformin. You can see the 10-year prevent score of 8.4% and his remaining labs. He's reluctant to take statin therapy. He's concerned about the risk, uncertain about the benefit as well. What would be most helpful? We could check an APOB, do high sensitivity C-reactive protein testing, order a creatine kinase, or coronary artery calcium testing. So the correct answer here is the CAC testing. So this patient falls in that borderline to intermediate risk. What's really going to provide the most information is getting that CAC score. And then based on that, we can either kind of round up the risk or round it down and can kind of work with the patient to figure out a plan. So the CAC score is obtained and it's 176, which is the 81st percentile for his age, sex, race, ethnicity. His LDL goal would then be less than 70 because that CAC score is above 100. So we would need to implement statin therapy initially to achieve that goal. So what's going to be the most appropriate initial pharmacotherapy? We have a variety of statins and doses here to choose from. But given that that CAC score was above 100, given his other risk factors, a high-intensity statin would be most appropriate, and so that's going to be atorvastatin 40 milligrams per day. Some key kind of summary slides here. So the key updates, earlier for longer. I think that's the simple message. Prevent ASCVD is the new risk estimator for primary prevention. You're going to see more and more about CAC testing to detect subclinical atherosclerosis. Goals of therapy are back. Lp(a) has a class 1A recommendation that we should screen everybody once. And non-statins, there's more clarity about their role and there's more of them available. So that gives us a lot of tools in the toolbox for patients that either refuse statin therapy or do not tolerate statin therapy. And I think we've covered these other kind of final take-home points pretty well. So I'm going to move us along so that we make sure we have enough time for some questions.